Good afternoon. This is Alessio LaManna from the Policlinico University Hospital in Catania. And together with Roberto Garbo from San Giovanni Bosco Hospital in Turin and Gabriele Gasparini from Humanitas Research Hospital in Milan, we welcome to this series of webinars organized with the support of Interventional Medical Device Solutions, IMDS. We know that in the last 3 months, we have fought against the COVID-19 pandemic, and all our efforts have been focused on the treatment of these patients. But now, since the situation is improving, we have to think to go back to our ordinary life, what is being called the new normality. That means that we have to think again to our patients with artery disease that unfortunately we could not treat in the last months, and that now have filled our waiting list. So now we have to go back to our cath lab to treat these patients. For these reasons, we thought to organize these webinars in order to take advantage of this time to review what are the most modern techniques in order to make our PCI procedures more efficient and safe. In order to do that, we will share real cases performed during our ordinary cath lab activity, and we will see how to use innovative tools that are available in most of our shelves that are very important in order to perform complex procedures in the most efficient way. So, but when we talk about complex patient or complex procedure, what do we mean? We may mean complex in terms of complex anatomy, that it means to have very complex coronary arteries in terms of various factors like calcifications, chronic total occlusions, bifurcation lesions, or we may have a complex hemodynamics, that it means patients with depressed LV function or high feeding pressures. They may need a mechanical circulatory support, or we may have a complex patient in terms of clinical factors, so single or multiple comorbidities that may impact on the acute or long-term outcomes of our revascularization procedures. Of course, in these webinars, we will focus on procedural issues regarding complex anatomies. And regarding our contemporary activity, if we look at the population enrolled in the Champion Phoenix trial, that is an example of a contemporary population of patients with both acute and chronic syndrome and chronic coronary syndromes undergoing PCI, when we look at this population stratified for some factors of anatomic complexity, we see how frequently we face complex situations, and in particular, those more frequent are bifurcation lesions, diffuse disease, thrombus-containing lesions, and calcification. Then, of course, may impair the result of our procedure. So it's very important how to deal to such complex anatomies in the most efficient way. So what is the best way to deal with these complex lesions? Of course, first you need a well-trained operator. And most of the technique that we may use in order to make this procedure faster and is to adopt CTO techniques. So it's very important to extend the use of CTO techniques to the complex lesions, because many of these techniques can be very effective for both performing complex PCI, but even sometimes to save very dramatic complications that may occur during complex PCI. Then we need the state-of-the-art devices that should be part of our armamentarium. And during these webinars, we will see how to use these several devices according to the specific features that each device have. So this webinar will focus in particular on bifurcation lesions and lesions in very tortuous vessels and in patients with diffuse disease. So now we start with the first case that will be presented by Roberto Garbo. It's very important, since this is a webinar, to share our experience. So please be as interactive as possible. We have a chat where you can do any question or comment regarding our discussion, that because for us it's very important to share our knowledge. Thank you very much. Roberto, please.
Thank you, Alessio. I think that just to say that my feeling is that we will have because of COVID-19, we will have an increase of complex patient because we have seen in the beginning of this period that many patients, they refuse to go to the hospital because of the pandemic. So we will have in the next month, and we had already in this last 15 days an increase of very complex patient, and so we think that I think that we will have an increase also of chronic total occlusion in the next period. So we have to be ready to treat this this complexity, and so that's why I think that this webinar is are really important, and it's important to share and to discuss together the best way to treat this complexity. We selected for this webinar a series of cases. Also, the first case is a case that should be a normal case, but you will see that a normal case can become a nightmare, and we need to be ready to treat also this case in everyday activity in the cath lab. So this was a case of a woman with diffuse disease on the proximal right and previous PCI on the LAD, on the proximal LAD, disease on the circ, and ostial left main that you can see that is not normal. You have a sort of lesion, 40% lesion with the diagnostic catheter in the ostium of the left main. And she was treated by, this is the, okay, the cranial view for the left system that show a lesion at the level of bifurcation of diagonal after stenting. And we decided to treat this right. This is what's important, that in this case, in this series of cases, we have cases that were done by all the interventional cardiologists in my cath lab. So that means that everybody is able to treat, to use these new devices for that help us to be more efficient. So this was a normal right PCI, and then after 20 days, we scheduled the woman for the LAD PCI. But the problem is that after the first injection, the 6 French guiding catheter develop a huge dissection in the left main, and with my colleague was great to put very fast a wire in the LAD. You can see this is the injection, and so how is the situation now? He has the wire that is in place in the LAD, so he is sure that the wire is in the true lumen in the left main, but he has a huge dissection of the circ with occlusion of this vessel. So after that, the patient developed cardiac arrest. She was resuscitated, and we have a sudden dilatation of the left main in order to restore minimum flow in the LAD. And then he decided to use dual lumen enhancer RX. That is the only one that we will see in this webinar. Is the only one that is compatible with 6 French and the balloon together. So we can do trapping balloon only with this great dual lumen microcatheter. This is the enhancer RX in the left main, and a Sion in the circ. So he takes the wire with the dual lumen. He was sure that the wire was in the true lumen in the left main, and then was able to gain the true lumen also of the circ. Then dilatation, restoring the flow in the circ, IVUS from the LED, because the LED was the goal of the procedure, and he want to understand. He show use the section in the left main. We are not able to show you because of time. And then left main LED PCI, stenting, proximal optimization technique. Again, dual with the third wire to rewiring. You can see the circ, in order to be sure that also the third wire is not behind the strut, because one problem of after stenting the left main is that if you go with another wire in the circ, sometimes you go between the struts and the wall, and when you do kissing balloon, you can have a sort of crash of the stenting in the left main. So we do a loop with an answer rigs after stenting of left main. You are sure that the wire in the circ is inside of the struts. This is the moment of trapping balloon. You can see 6 French balloon in the here in the guiding catheter, trapping balloon, and removal of dual lumen. Again, kissing balloon, final pot, and very good final result also in the LED after the diagonal branch. So this was a great demonstration of how the efficiency, how the knowledge of these devices, and if you know the way to exit from complication, you can solve this nightmare. So Alessio, if you want to, Gabriele, if you want to have a comment.
That is, I think that this is a very nice example of how to solve a dramatic complication, because of course you must be very fast and to be more efficient in order to convert a life-threatening complication like the one you faced. So in this case, the dual lumen microcatheter really was helpful in order to make the procedure faster and more efficient. I would like to know from you, in such a condition, what is your most favorite wire to use to wire the side branch when there is like in this case, a dissection?
Yeah, this is a very important question. In this situation, I have normally I take very good wire like Sion blue or a regular Sion, or I can try also with the run through. That is a very good wire. Sometimes I have a good success with the Suo 03 that can be exit from dissection. When I need to recross stand strut and have for instance a jailing of diagonal branch and dual lumen, I'm able to, I like very much ultimate bros 3, that is a stiffer wire, is a CTO wire, 3 gram at the tip, but also the last 3 centimeter of the ultimate bros is stiffer than a regular wire, so it means that we can avoid the risk of prolapse of the wire in the main branch. But in this situation, when you have a iatronic dissection, I think I will start with the Sion wire in this situation.
Okay, thank you.
Well, I substantially agree with you, Roberto, and I think that the best wire could be different depending of the situation, and in my opinion, I love to use in situation like that the ultimate bros 3, because it's a very effective way, it's effective wire because of very high and very good tactile feedback, so you can feel on your finger the wire progression, and it's a very safe wire if you are used to use it. And before starting the next slide, I would like to underline an important issue regarding the device. And Roberto said that in his cath lab, all the staff or the interventional cardiologists are used to treat complex PCI and complex lesion, and are used to manage complication like this one. I think this is a very important issue, because one operator could learn how to use it, also seeing a colleague or assisting to a webinar like this one, because the best way to become used to use a dedicated device is just to try. But before trying, you have to modify your mindset, because you have to keep in mind that in that situation you have to decide very quickly the best solution and the best device to use it. So you have to modify your mindset, and the best way to modify to become used is to assist and to share experience, to see other operators, how can they solve some situation, or how can they use a different device. So this is a great opportunity. I'm very honored to be part of this interesting webinar, because you never stop to learn, and sharing different experience is the best way to learn. Now, can you see my screen now?
We can see you.
Yeah. Okay, just a second. I start to. Okay. Now you see the slide presentation. Okay, so, we are talking about the dual lumen microcatheter. This is a very useful device that has been recently introduced to facilitate complex PCI. And the first application is to treat bifurcation, but nowadays this device could be used in several different situations, and one of the most frequent situations is in treatment of CTO lesion, but also in solving some complication like dissection, like in this case, because the presence of two different lumen could help operator in order to regain or to gain the true lumen. So these microcatheters share a common feature, the presence of two different lumens. One rapid exchange lumen that is at the tip. This is a very important aspect, because sometimes could create some mistakes, but differently from the single lumen microcatheter that has the over-the-wire lumen on the tip. In this case, the rapid exchange lumen is on the tip, and the over-the-wire lumen it's lateral in this exit port. So we have just to become confident. Operators should become confident in order not to confound the different lumen. So the most frequent application is in case of bifurcation. It's very simple to use it, and the wiring for wiring or rewiring a side branch after bifurcation treatment, or when the takeoff of one of the side branch could be very difficult or angulated. And also we can use it to facilitate the reverse wire technique in bifurcation with unfavorable takeoff. And finally, one of the most frequent situation during CTO procedure is to use the dual lumen microcatheter to perform the modern dual lumen parallel wire technique. Because nowadays the parallel wire, the best way to perform a parallel wire technique, once the first wires went into the subintimal place, is to advance a dual lumen microcatheter with a second different guide wire, stiffer than previous one, and try to regain the distal true lumen. This is the the modern parallel wire. This is an example, this is a video of the classical situation of rewiring in case of stenting of a bifurcation lesion. Sometimes when you put two stents, it's not always so simple to recross the wire. the side branch. So in this case, the dual lumen microcatheter could be very useful. We all of us saw the previous case in which the dual lumen microcatheter was used in a bifurcation in case of complication, in case of dissection. Once you have the first wire in the distal wire into the first wire into the distal true lumen, you can use the second lumen through the exit port. You can advance a second wire and to gain the side branch without the risk to enter into the subintimal space. But regarding the current availability of this dual lumen device, there are several different devices available in Europe, but the last one, the Recross, we will talk about the Recross in the next webinar, because it's quite different from the previous ones. And so these are the classical dual lumens, the Enhancer RX, Fine Duo, Sasuke, and Twin Pass. All of these microcatheter, dual lumen microcatheter, share a common feature to have two different lumen, one rapid exchange and one over the wire lumen. Then obviously there is a marker on the tip that help operators to identify the tip, but there are some difference in between different dual lumen microcatheter. It depends of the technologies, because if you use some dual lumen microcatheter has a metallic marker on the tip, the Enhancer dual lumen microcatheter, the tip is made from tungsten, that it's radio opaque, and help us the physician to identify perfectly the distal part of the tip and to avoid a deep engagement into a lesion or into the vessel. And then there is a second market from the exit port that is made of tungsten. So in this case, it's very helpful to identify the exact position of the exit port for the second wire. This is very important because these microcatheter are not really torqueable microcatheters. So when you advance it, it's not really simple to rotate it. And in this case, you have to identify very well where is located the exit port. So the second market, it's very important to help physician to advance to identify the exit port. Then there are other difference, and the main difference I think is the shape of the distal part, because you can have two different shapes. This is an example of the guiding catheter. Inside the guiding catheter, inside the inner diameter of the guiding catheter, you can advance a balloon and you can advance a dual lumen microcatheter. Why? Because the best way, maybe the only way that we have to remove this device is provided by trapping balloon, because you can use the extension wire, but it's not so safe in terms of radiation, in terms of losing of the position or contamination of the wire. So the best situation in order not to lose both of the wire is to perform a trapping balloon technique. But if we have a spherical shape like the Twin Pass or like the Fine Duo, this is not compatible with the 6-French balloon because of the diameter. But the Enhancer RX has a oval shape that lead us to perform the trapping balloon into a 6-French. So for this reason, it's very important to have in mind, to keep in mind this difference, because if we are performing a standard PCI, maybe we are using a 6-French guiding catheter. We have some problem with a bifurcation or with a complication such as a dissection or left main dissection. We have to be very quick, and we have to have very clear in our minds the compatibility of all the devices that we are using. So in this case, if we have the availability of an Enhancer RX in our cath lab, this is the best device to use it in a 6-French guiding catheter, because it's compatible with the trapping technique using a standard balloon. This is an example of of the concept that I try to explain you. So this is a fine duo. This is not compatible due to the spherical shape of this device. And this is the example of the twin path that it's very similar to the previous one, to the fine duo, but it's not already compatible with the trapping balloon into a 6th range. And this is the reason why, if we use an answer RX into the 6th range guiding catheter, we are able to perform a trapping balloon technique using a standard rapid exchange balloon due to this oval shape. Obviously, if we reduce the space between the two lumen inside, maybe we can gain a smaller profile, but we can lose some pushability of this device because it's smaller. So to overcome this problem, there is a stylet inside that could help physician to advance it. And then once the microcatheter is delivered in a position, we can remove the stylet, and then we can advance the wire. And one of the most useful aspects is that we can re-advance a second time and a third time the stylet if you have to reuse the dual lumen microcatheter. Another interesting device that we can help us when we have some doubt, or we can when we haven't the correct device to perform a trapping balloon into a 6th range using a dual lumen microcatheter, we can overcome this problem if we have the availability of the Trapit. The Trapit is a dedicated balloon that was developed to perform the trapping balloon. So we can advance this balloon that is has a lower profile, a lower outer diameter compared to a standard rapid exchange balloon. So in this case, we can perform without any problem of compatibility the trapping balloon with a dual lumen microcatheter into the 6th range. I mean, with a dual lumen microcatheter with an oval shape such as Sasuke, if you don't have the enhancer RX available in your cath lab. Obviously, if you are using a different dual lumen microcatheter with a spherical shape, you cannot perform the trapping balloon into a 6th range, even if you advance a trapped balloon. So I give the line to Roberto to go on with the second case, or maybe if there are some questions, please, Alessio, feel free to interrupt us for the question from the chat.
So thank you, Gabriele. Very nice presentation. So what we have got from your presentation is that nowadays everybody should have a dual lumen microcatheter available in his own cath lab, because it's very important in many situations. In complex bifurcation lesions, if we go subintimal with a wire, and then it can be useful to re-enter the true lumen. But take into consideration a situation where we don't have a 6th range compatible microcatheter with trapping balloon like the enhancer RX, and we have another round shaped dual lumen. You don't have the trapped balloon, so how to use such kind of dual lumen? How to remove this kind of dual lumen from the coronary artery? Since you cannot do the trapping balloon in the 6th range guiding catheter and you don't have the trapped, what do you normally do in this case? If you are forced to use a dual lumen microcatheter in a 6th range guiding catheter without oval shape.
But in this case, in this dramatic scenario, when we don't have any other possibility, I think the only way to remove it is to use extension wire.
Okay, that is not really the most efficient way to perform this complex procedure. So it's better to have.
I don't like the extension wire, but if you don't have any other possibilities, the only way is to use the extension wire.
Okay, thank you. Because this is a situation where, yes.
Yeah, I think that you had a good question, but I think that the only way to do is to avoid to be in this crazy situation. So exactly. you need to know in advance that in your cath lab you need to have a good dual lumen that is 6 French compatible. I think that this is the key, because otherwise you are in big trouble. Because also you can try with the you can with the dual lumen, that situation you cannot do also the Nanto, because it's not a regular single microcatheter, but you are in big trouble in that situation. So I think that extension, you need to have extension in some situation, because also we will see probably in the last webinar, you can have a complex retrograde in which trapping balloon is not the solution. Sometimes you need to have both trapping balloon and extension in complex retrograde when you need to change microcatheter. But in situation you are in trouble without the good device. Just to add that Enhancer RX has some unique feature, really useful. What Gabriele said, that the 2 marker, the tungsten marker, we can see exactly the exit of our second wire, as he said, and we will see in this case how is important. Also the stylet increase the pushability, and we have a very good microcatheter with a good flexibility, and with the stylet we can have both, so push and flexible device. If we can go with another case, another straightforward STEMI with the 51-year-old man, was done in night by another colleague. We can have this case every night. We can see that it's not a good takeoff of the right. This is a JR4 that was not a fantastic approach. So our colleague decided to use Amplas left 1 for PCI. So this is the Amplas left, and the crossing with the regular run-through wire in the situation of STEMI. This is floor storing of the crossing, real time, not so easy. At the end, he was able to cross, but he went into a side branch. This is clearly not the normal course of the right. This is the first injection, and as you can see, he tried to do an attempt with multiple attempts. I think with the regular second wire, also Sion wire, Sion blue wire, and he was not able to gain the right, because you can see the bifurcation is full of thrombus, and is not an easy bifurcation to deal with. And so he decided to go with dual lumen, and you can see here clearly that the Sion black went exactly in between the 2 marker. So he placed the dual lumen exactly at the level of bifurcation. So the rapid exchange lumen is distal, and the over the wire lumen is proximal to the. So it was real-time fluoroscopy storing. You can see how easy. So you have an increase of support with the dual lumen, and increase of directionability. So it was really easy to go there. And then balloon dilatation, kissing balloon dilatation, you can see 2 balloon. And after that, as usually, we have a sort of a squeeze, thrombus of squeezing with loss of the distal right. Thrombus aspiration, I think, was an eliminate device. He has to remove the side branch wire because of 6 French and this device is not available and is not possible to use with the 2-wire in the 6 French. Also, you can see the backup that is not good. So it is decided to take a second device that is really essential in our catalog. It is this was the result after thrombus aspiration. He decided that he need to stent, but he want to use guide extension with the distal anchoring. You can see how easily the guide extension went in the mid of the right, and then it was able to stent, and this is the final result after stenting. So in this case, very normal case of STEMI, he was able to use both dual lumen and the guide extension to have a very good result. So we can exit.
Yeah, thank you, Roberto. Very nice case. So demonstrating the importance of the guide extension in such a situation where we have a poor backup. So it's very important in order to make a more stable situation, the use of guide extension in order to allow the stent deployment. So there is a question that has been done just a few minutes ago regarding the use of the Nanto technique in order to remove the microcatheter. You already almost replied to this question, but I would like to say that the Nanto is very effective when removing a single lumen microcatheter, as you said, because it works very well in, we may say, 99% of cases. So if you have to remove a single lumen microcatheter in a not complex procedure, you can use very easily. It's very fast. But in more complex procedure, where you have to exchange more wires, more microcatheters, I think that the trapping balloon technique is the most efficient way. What do you think about that, guys?
But Alessio, I think that I don't use anymore the Nanto technique in my cath lab, my cases, because I've seen that with the Nanto, you have only the risk to move your wire. Also with a single microcatheter, I used the Nanto before we learned from Japanese like 15 years ago how to use the trapping. Is the simplest way and the most controllable way, because if you trap the wire, your wire doesn't move anymore, and you avoid the risk to move the position of your wire. Normally with the Nanto, you can have a distal movement of your wire, and normally we can have a soft polymeric wire like Fielder XTA, Fielder XTR, or Sion Black, and or Pilot, or many polymeric wire that we can have distal perforation. That we know that distal perforation is a risky complication. So I suggest not to use Nanto technique, because with the trapping balloon you can have a really easily removal of your microcatheter without any risk.
Gabriele?
Absolutely. I completely agree, and I discourage nowadays the Nanto technique, because once we learn to use the trapping balloon, it's very simple. It's simple, quick, safe, and effective. So, and also cheaper. So we should use it, and I discourage to use the Nanto technique nowadays.
Anyway, what is important is that the Nanto technique doesn't work with the dual lumen microcatheter. So in order to remove the dual lumen, you cannot use this technique, because you will lose even the wire, because it will not keep the wire in the correct position. Do you agree with that?
Yeah, totally.
Okay, thank you very much. There are no more questions, so please, Gabriele, keep going.
Okay, so the next part of our presentation is to talking about the technical feature of the guiding catheter extension. As we saw in the previous case, the utility of this device. I think now it's an admissible device, so we should have in our cath lab a guiding catheter extension, and because it's one of the most effective way to improve support. You can see in this slide different technique that we can use it, and I think that the best technique to improve support are the use of guiding catheter extension, of the anchoring technique. But to perform the anchoring technique, you should have a large bore guiding catheter, or you should have a side branch that is suitable for the anchoring technique. In cases in which the anchoring technique is not really possible, the use of guiding catheter extension is the best way, the quickest and the safest way to improve support. This slide show you how can the support improve depending on the distance of the engagement of the guiding catheter extension into the coronary artery. So if we advance just a few millimeters, we can improve our support, and it could be useful in case of proximal lesion, in case of absence of calcification or bifurcation. But in other cases, in different cases, when we have a distal lesion or a very diffuse disease or calcification, sometimes we need to advance it. And if we advance the guiding catheter extension, for an example, 15 millimeters, we can see from this picture how the support could improve, just advancing 10 millimeters more the guiding catheter extension. So this is a very interesting review that was published from our friends Professor Carlo Di Mario a few years ago, and I totally agree with the authors regarding the assessment that the guiding catheter extension is nowadays an admissible tool in the armamentarium of modern interventional cardiologists, because we are very used to find to diagnose in our older patient lesion, tight lesion in tortuous anatomy, or with a very high calcification, or even in 30% of cases with CTO. So this is the most frequent situation. These are the most frequent situation in which we can use the guiding catheter extension to improve the outcome or to improve the technical success rate. Other possible indications are reported in this table, and I think that we can underline the situation when we are to use to advance a Burr, a Rotablator, because the delivery we are going to see in the next cases from Roberto, the guiding catheter extension could help us to advance the Burr in a calcified lesion or in tortuous lesion. And here in the bottom are reported other possibilities, but I think that nowadays it's not really anecdotal cases, because we have to consider the opportunity to use the guiding catheter extension as a first strategy in order to manage the Rotablator entrapment, and we are going to see also another very interesting case in the next few slides. So I think that it's a very useful device. And also in this case, we have to know that there are different guiding catheter extension available in Europe, and there are some difference. And the most important aspect that we have to know and we have to consider when we decided which kind of guiding catheter extension use is three different parts: the tip, the transition point, and the shaft. And also, I think that the coating is very important, because we should advance this device into the coronary artery. So we should avoid the razor effect, For this reason, a traumatic tip is very important features in this device. Then pushability. Pushability, it's obviously important when we have to use a device that is needed to improve the support. So pushability, it's very important because we have to advance it into calcified or tortuous or very distal lesion. And then also for the same reason, the coating, the hydrophilic coating, in order to improve the trackability of this device into the coronary artery vessel. And another important aspect, this is mainly due when we have to advance the device such as stent, is the transition zone, because we have to reduce as lower as possible the friction when we advance a stent into the distal cylinder. So also the transition zone, it's a very important aspect to consider. This slide shows you the technical feature of the Gideon Gideon guiding catheter extension. That is the guiding catheter extension with a very atraumatic tip compared to the competitors. This is due to the fact that the tip is obviously radiopaque, but is made in tungsten also in this case. So if we remove the radiopaque marker from the microcatheter, from the guiding catheter extension, and we put the tungsten tip, we can achieve a softer tip. So in this case, this is the only guiding catheter extension without a metallic marker on its tip, but with a soft radiopaque tungsten tip. This is the main characteristic of the guiding catheter of the Gideon. And it's available in 4 different sizes. And a very important aspect to keep in mind is that it's available in 5 French size. It could be very useful in some complex retrograde bifurcation through ipsilateral channel, but it's not the topic of this webinar. And this is a product comparison that try to show the main characteristic of different devices. So if we consider the guideliner, one of the most important aspects is to consider that it's available in extra large size. I mean, the length of the distal cylinder. For all of the others, guide catheter extension, the distal cylinder is the length of the distal cylinder is 25 centimeters. In this case, the extra large could allow you to advance very deeply, very distally in case of need. The Gideon is the guiding catheter extension with the most atraumatic tip, that it's very important, especially in case of very calcified of tortuous lesion, when you have to force it, to push it very strong. In this case, you can avoid the razor effect, or even if you have to advance it through a previous implanted stent, in this case, you can reduce the likelihood of deforming the previous implanted stent. And for the guideliner, I think that the most important technical aspect that we have to know is that the internal luminal diameters is bigger than the others. It's not so bigger, but sometimes, especially if you have to advance a rotabu through a guide catheter extension, the Godzilla has this big diameter that could be useful in that situation. Then, after we know the different in technical feature, we should also to be able to advance it into the coronary artery. There are different steps depending on how deeply we have to advance it, and we can start just for a short protrusion with a direct advancement, or in case of failure we have to push it further, and then we have different strategy and different technique to to advance this device. I think that it's very important to know all the different techniques, because sometimes it's not enough to advance it just with a direct advancement, because sometimes it's not possible in that way to cross the lesion or to advance this device distally. So the first and the simplest way is to achieve a direct advancement. When it's not possible, we can use a distal anchoring technique that it's very useful and consists in advancing distally a balloon to inflate the balloon distally, and then in this case we anchor the wire, we anchor the all the gear, and we can push on the guide catheter extension, and at the same time we can pull gently the balloon in order to put in tension the wire and to facilitate advancement of the guiding catheter extension through tortuous and calcified lesion. Another interesting technique, it's sometimes similar to the balloon-assisted tracking technique that consists to inflate the balloon halfway inside the distal part of the guided catheter extension and the vessel. In this case, you can advance at the same time both the balloon and the guide catheter extension, avoiding the risk to create some dissection, some Rexor effect, or to deformate a previous implanted stent. I would like to show some cases just to have an idea of the different technique. This is a direct advancement. It was not really difficult to advance the guide extension very distally because it was advancing through a saphenous vein graft. But in this case, we have to consider that the distal cylinder it's at 25, and if you advance 25 centimeters, so if you advance so distally, the catheter extension sometimes could be better to have an extra large guide catheter extension such as the GuideLiner. This is due not for a technical reason, because all of the guided catheter extension could be advanced very distally, but it's a question of safety, because in this case the transition zone comes into the vessel. So when you withdraw the device, you can create some iatrogenic damage of the vessel of the graft. But this is an example, and in this case, I didn't have any extra large device in my cath lab. So I perform a direct advancement very deeply, so it was very simple. Then look at the tip of this guiding catheter extension that was advancing behind the crux, and then it was very simple to deliver a balloon, and then after dilatation to deliver a stent. And this is just an example of direct advancement, and this is a different situation with a very deep intubation, also in this case through a graft. But you can see how was effective a distal anchoring balloon to let me to advance the guide catheter extension very distally in this tortuous anatomy and this distal right coronary artery. And then another interesting aspect is when you perform the distal anchoring technique and you need to advance the guide catheter extension beyond the balloon, you can advance it during the deflation. You can continue to advance the guide catheter extension during the balloon deflation. So in this case, you use the balloon as a rail, and you can advance more distally the guide catheter extension, like in this case. This is another example of when I perform the balloon assisted, the third technique, inflating halfway the balloon through the distal part of the cylinder and the vessel in order to avoid the distortion of a previous implanted stent. This is a technique that it's very useful in this case, or also when you have a strong calcification, because in this case you can advance smoothly the interior gear into the distal vessel. This is the picture that the previous video. In this case, inflating balloon halfway, you can advance it together at the same time. And in this case, you can perform the same technique even if there are not previous deployed stents, but in case of tortuosity or calcified lesion. It's very useful technique. And this is the last example, and in which the use of guiding catheter extension was very effective in treating this obtuse marginal. In this case, we had to overcome this dual, a double 90-degree bending through a previous implanted stent. So we had to cross the strat to advance the balloon, and then finally to advance the stent to cover a very long dissection that the operator experienced during treatment of this obtuse marginal. So it was possible to advance the balloon without any problem to the strat through this 90-degree bending. But once we had to advance the stent, obviously it was not possible. So in this case, you see the guiding catheter extension that led us to improve our support. And this is a very interesting fluorostor, because you can appreciate the advancement of the balloon. I advanced the guide catheter extension behind the strat of the stent, behind the bifurcation. Then I had enough support to advance the balloon to perform a distal anchoring. This was the distal anchoring, and then during the deflation of the distal anchoring, I advanced just a little bit more the guide catheter extension to deliver the first stent, and then to deliver the second stent in a TM protrusion, and this was the final result with a good restoration of antegrade flow. So the conclusion is these devices are very effective, and I think that in all cath lab this device should be present, should be available. But we know the advantages of this device, but we also should keep in mind that we can have a possible complication with this device, especially if you have to use it in a very aggressive way. So this is the list of possible complication, but it's not the topic of this webinar. So if you are interested, you can, I suggest you to read this very interesting review. So Alessio, I finished this part of the slide. So if you have some question, feel free to ask me.
Thank you, Gabriele. Again, excellent presentation, showing all the application of the guide extension in such complex anatomies. I think that if we think about the past, when this kind of devices were not available, this explains why there were so high rate of failure in the PCI procedures. Nowadays, we can treat very complex patients that having results that are similar to that of, I think, surgery, because we are able to implant stents everywhere in a very effective way. So there is a question from our colleagues, in particular from Ayman Tantawi, asking is there a recommended balloon size and inflation pressure for the balloon guided advancement? So Gabriele, what do you think?
It depends on the diameter of the vessel, because if you perform distal anchoring, you should size the diameter of the balloon depending of the diameter of the vessel or the place where you want to inflate the balloon to perform the distal anchoring. I mean, for example, if we are treating the right coronary artery and we should perform a distal anchoring at the level of the distal RCA, sometimes you can use a 2.5 balloon, but there are in some cases in which the distal RCA are bigger. In this case, if you plan to treat to cover with the stent, you can use also a 3.0 balloon without any problem, because if you should respect 1:1 compared to the diameter of the vessel. But if you plan to treat it, it's not really a problem, because even in case you can have some iatrogenic damage of the vessel, then once you advance the guiding catheter extension, you cover it with the stent. So there is not a rule, because it's depending of the diameter of the vessel. Differently, if we are considered to use the balloon-assisted tracking, we have to inflate a balloon halfway into the distal cylinder. We can use a 2.0 balloon or no more than 2.5 balloon, because with a 2.5 balloon you can destroy, with a bigger balloon you can destroy the distal part, the tip of the distal part of the cylinder, or the tip of the guide catheter extension. So in this case, if you want to, these techniques are different. The balloon assisted is not to achieve a distal anchoring, but just to advance both of devices together at the same time. So 2.0 is the best diameter in the distal anchoring, depending of the diameter of the vessel.
Thank you, Gabriele. Do you think there is any importance in choosing a guiding catheter with or without side holes when using guide extension? Does it make any difference?
Yeah. Okay, obviously we have a reduction of the flow inside the guide catheter when you advance guide catheter extension. So it's not always predictable, because sometimes we start, I use the side holes only in CTO PCI or in some other different ostial lesion. But in my standard practice is, if I have to perform even a complex PCI, I prefer to use without side hole, guiding catheter without side hole. And then if it's needed to use a guide catheter extension, I use it. But you should use it in the proper way in order to use it for the lowest time possible. If you use it in the correct way, you can advance it even in a guide catheter without a side hole.
Thank you. And another issue is, as you mentioned during the presentation, the transition zone is very important, because it's a place where often we may experience frictions when advancing in particular stents. What is your suggestion when an operator is trying to advance a stent and this is hard to do because it feels some friction, and sometimes you can even destroy the stent when trying to advance it? What to do in such a case? When you need to position a stent, you need the guide extension, because otherwise you cannot get up to the target site of the vessel. What to do in such a case?
But the first thing to do is, when we advance, before considering the transition zone, in order to avoid any problem to advance the device, is to identify, once you advance the guide catheter extension, you should cover with on the table, in order not to avoid the twisting of the wire on the shaft of the guide catheter extension. Because sometimes if you use the wire and the shaft of the guide catheter extension, you don't realize that the wires is twisted around the shaft. So in this case, it's very difficult to advance, and sometimes operator can think that it's a problem of transition zone, but the problem is due to a twisting of the wire around the shaft. Then the second step is to consider, it's very important, the transition zone, especially when we advance the stent. And all the companies work very hard to overcome this problem. Since the first version of the first guiding catheter extension until now, they work on this this part, and I think that now all the devices that are available in Europe have no really problem with the transition zone. Sometimes a problem could be represented if the transition zone is at the level of the aortic arch. So in this case, we can have some problem in order to advance the stent into the distal cylinder, due to the position of the transition zone just at the level of the aortic arch. But in this case, you can advance just a few millimeters or two, withdraw, and you can solve this problem.
Okay, thank you, Gabriele. Let's move to the next case presentations. Please, Roberto.
I have a short comment on your discussion. I think that my practice doing balloon assisted advancement of gut extension, I take a small balloon like 1.5 millimeter because I don't need to have a big balloon in order to have this kind of technique. When I need to have distal anchoring, it depends on the vessel size. So at least 2.5 probably is the best. And if you have a bigger, as Gabriele said, we need to go with the bigger size of the emitter or balloon. And your last point is really crucial, because we will see now some cases of rotablator with gut extension, because we have a very good experience with this technique for very complex cases, and the transition part, as you mentioned, is the key. And my suggestion is when you have a friction, not to push your stent, because if the stent doesn't go, pushing is not, if you force, you make a rupture of the struts, and so you need to modify the position of your gut extension, because probably, as Gabriele said, you are in a curve in the aortic arch, and the transition is the key. So also with rotablator, you have two possibilities. The first one, that one I suggest at the beginning, is to put your burr when you need to use gut extension and rotablator burr. Start putting the burr inside the gut extension, outside of the patient, and you go in your coronary artery together with the burr and the gut extension. And because it's the safest and the easiest way to do that. But when you need to advance the gut extension before, because you need to gain a position, then you need to go with the burr in the second phase of your procedure. So you have to be very careful about the transition, because sometimes you can have a friction. And the third point, very important, is the compatibility of your gut extension and the burr. So with the 6 French gut extension, you can go with a 1.25 burr. With 7 French, you can go up to 1.5 millimeter burr. So to see this case is a case of everybody will treat with rotablator. I think is an old woman with the previous treatment 3 days before with left main circumflex PCI, and we need to treat this LAD diagonal. So we want to use the gut extension to avoid to have a sort of damage of the recent stent placed in the left main. So this is a gut extension. You can see Gideon 7 French and the 1.5 millimeter burr in the diagonal. You can see you have the gut extension in the proximal LAD, and easily you can advance your burr. You can do rotablator with in the diagonal. This is the fluoro storage of the burr. Advancing in the diagonal, you increase your support. You can see also the guiding catheter coming back in the left main. So with the guide extension, you increase your support in this tortuous anatomy and huge calcification of the vessel. This is the situation in which the burr crossed the diagonal, and then drug-eluting stent implantation. We will see the stent coming. With the gut extension, we have a great support, stenting, and then we need to treat the LAD. So burr and rotablator 1.5 millimeter burr in the LAD, stenting, kissing balloon, IVUS, and very good final results. So this was a very good case for this technique. Take home message: 7 French and 1.5 Burr is compatible. Use of child and mother as proximal protection of the stent, and it's better to assemble outside. In the first case in which you try this strategy, for sure you need to assemble the system outside. Another case, this is a very complex case. It was the first in man case of rotablator with the 2-wire, very complex patient, huge calcification in right and the left system, previous PCI with rotablator on the right and on the circ, residual calcification, extensive calcification in this huge diagonal. You can see here this point in the mid of the diagonal, and the calcification of the LED. This is the spider view. You can see here the really calcified diagonal and the bifurcation. And after the stent on the LED, we went to 8 French guiding catheter, go to LED rotational atherectomy, 1.5, and then upgraded to 2 millimeter Burr. So this is 1.5, and now we can see the 2.0 millimeter Burr in the LED. Then stenting of distal LED to touch the bifurcation. This is very important, that we need to treat the diagonal. We try to avoid rotablator, but the balloon was not able to cross. So we need to use this new technique in order to save not to remove the wire in the LED, and to do rotablator in the diagonal. We put a 7 French guide extension alongside the wire in the LED. So the wire in the LED is a protection wire, and you can see we have the guide extension that is out of the wire in the LED, is at the level of bifurcation, and we have a rota wire in the diagonal. We advance, then we were obliged to advance to assemble the Burr out inside of the patient, but was easy to go there in this case. You can see, so we have the guide extension outside of the wire in the LED. Inside we have the rota wire in the diagonal. This is the time of ablation in the diagonal with the wire in place. We published 2 years ago on Eurointervention. After that, we put a stent in diagonal with the DK crush, left main LED, kissing balloon, IVUS, and very good final result of this very complex anatomy. So also this case show how useful is to know how to treat this kind of patient with the guide extension. Then the last case, as Gabriele mentioned, how to use to solve a complication. Burr entrapment is a complication that everybody face in his career during the cath lab. This is a case of a tortuous right doing by radial. You can see the tortuosity, and we have a stack with the Burr in the middle of the right. This is the way you cut with the scissor your system. You remove the sleeve, and you have in place the Burr in the artery. After that, you put a guide extension inside of your system. You can see here. It's very easy to do that because you have your Burr that is a jail in the artery. So you have the best of pushing system, is the best distal anchoring for your guide extension. I can say. You can see here we have the Burr trap, and then the guide extension coming in front of the Burr, and then at this point you need to pull together the Burr and the guide extension. I show you again, coming the guide extension in front of the burr, then okay, now you pull everything out, and the guiding catheter, the amplats, is in the remain in the ostium of the right. With this technique, we have 100% of retrieval of our burr, because in this situation, if you're not able to retrieve, you have to go to the surgery. So this is a check. PCI with balloon, non-compliant balloon, drug-eluting stent, and final result. So this is my last case, Alessio, and then you can go.
Thank you, Roberto. These last three cases were very illustrative. Always important to have guide extension in your catheter when you treat very complex patients using the rotablator. Now, how essential can be the use of this device when you are in troubles, when treating bifurcation with rotablator, when you have your bar stuck in the coronary artery. So very excellent examples of how to use guide extension in such complex situations.
Yeah, I think that just to have a last comment, that dual lumen and guide extension really changed the game in the in complex procedure, and enable us to treat this case with faster and with more efficiency. So I think that there are also we will see in chronic total occlusion in the next webinar how they're useful, but also not in CTO cases. They are really essential.
Thank you. Now let's move to the engineer point of view. Ms. Susan Lore from IMDS will show some technical specifications of these new devices. Please, Susan.
Thank you very much, Dr. LaManna. My name is Susanne, indeed, Susanne Lore. I've been working for IMDS for 4 years now, and as an R&D engineer, I've been involved in most of the IMDS devices. And today I would like to share some of an engineer's perspective on design perspectives of some of those devices. And based on today's topic, I would like to focus on guide extensions, dual lumen microcatheters, and trapping balloons. The last few cases that we have seen were about the uses of guide extensions. So I'd like to start with the Gideon Hydro, which is IMDS guide extension. So we've seen several indications of guide extensions, and one of them is that guide extensions can be used for stent placement. And for that, we've designed the Gideon with a tip that is safe, soft, and fully radio-opaque. So for delivery of devices, and especially stents, it's very nice, very beneficial if you know where your end of the guide extension is exactly when you're looking at the angio. So the tip of the Gideon is fully filled with tungsten, so therefore it's visible completely on the angio, and you know exactly where the distal end of the guide extension is. So when you're placing a stent and you want to expand the balloon, you know exactly where you can expand it, and you don't have any risk of expanding inside a guide extension. While looking at the competitors, as also told before by Dr. Gasparini, they all have a radio-opaque metal marker ring. And since this marker ring is very stiff and sharp, it's not possible to place it at the very distal end of the tip of a guide extension. So therefore, you always have to take into account a few millimeters before you really know where the distal end of your guide extension is. Another thing which is very important for guide extensions, since they are quite bulky and large compared to, for example, microcatheters, it's important that the distal end is very safe, because you never know if you feel an obstruction or any kind of reason. You don't want any vessel any damage on the vessels. So the disadvantage of this metal stiff marker ring on a guide extension of the competitors is that, as you can see in the picture on the right, that when you push a rigid object towards the distal end of a guide extension, the metal ring will always remain its shape, which is of course not really, can cause some kind of risk to the vessels, since it will really change it will remain the shape, so it can change, it can affect the vessels. When you are looking at the Gideon tip, it is completely soft, so when you push a rigid object against the Gideon tip, it will deform completely. And of course, as you can imagine, this is not causing any risk to the vessels. I have to say that this deformation is elastic, so the tip of the Gideon can always get back into its original round shape. The Gideon Hydro is also designed to overcome patient challenges, and therefore the hydrophilic coating and coiling design of the shaft is very important. So in order to have a guide extension that can support deep tortuous crossing, it is important that the surface of the distal shaft is very lubricious. Therefore, we implemented a hydrophilic coating on the Gideon Hydro. We did testing, as you can see in the graph on the top, and where we tested the friction over the surface of the distal shaft. And as you can see, the Gideon Hydro has lower surface friction compared to a guide liner or a guidezilla. You can imagine that friction is something that you don't want for a guide extension. So the lower the friction, the better, because it means that the lower the friction, the higher lubricious the shaft is, and the easier it can cross in tortuous vessels. Well, if you design a guiding catheter that is able to cross deep tortuous vessels, it is important that the lumen integrity is always remained optimally. Because you don't want, during the delivery of, for example, drug-coated stents, that there's any interaction with the shaft and the coated stents. When we are looking at the competitor devices A, B, and C, we see that in B, there is a braided shaft in the distal shaft of the guide extension. We know that braiding with a round wire is not beneficial for a shaft to be in tortuous bends because it can get oval. And as I just mentioned, you don't want any deformation of your lumen in order to have interaction, which can result in interaction with your coated stents. A and C, excuse me, are both having a coiled design, and so has the Gideon Hydro. We think it's important to have very closely packed coiling because it keeps the lumen integrity even better, and it remains to push while still keeping the flexibility to be able to support crossing of deep tortuous vessels. So in summary, the Gideon has a very safe, soft and fully radiopaque tip, and the distal shaft is designed to cross very deep and tortuous vessels. Now let's go to dual lumen microcatheters. The dual lumen microcatheters of IMDS is the Enhance RX, and just like the Gideon, it is designed with a true distal and visible tip. So also the tip of the Enhancer RX is soft and fully visible under the angiogram. But as explained before by Dr. Gasparini, since a dual lumen microcatheter can have an extra guide wire inside the second lumen, it is nice if it's known where this second exit port is directing to. So therefore we made the second exit port of the Enhance RX also fully visible under the angio, as you can see on the left. The Enhance RX is designed to give extra support while keeping the lowest profile in order to make it 6-French trappable. So the Enhance RX is gaining extra push by a removable stylet that can be inserted into the over-the-wire lumen of the catheter. So when the device is advanced with a guide wire inside the tip through the rapid exchange lumen, the over-the-wire lumen is free and the stylet can be inserted in this over-the-wire lumen. This is giving a lot of extra support, but you don't lose any profile because of that. So looking at the profile, as we also, which has been discussed in this webinar before, but the profile of the Enhance RX is 2.3 French only. This makes it trappable in a 6-French guiding catheter because, as you can see, the space left in a guiding catheter is more than 1 millimeter, and a regular balloon catheter is 0.8 to 2 millimeter average. So a regular balloon catheter can always fit next to an Enhance RX in a 6-French guiding catheter. Also, a trapit can be used, which I will explain in a minute. So to summarize very shortly, the Enhance RX dual lumen microcatheter is having a fully distal exit ports in the distal end, and by the removable stylet, it's having a lot of push, while keeping the profile low. It is always trappable in a 6-French guiding catheter. The Trapit is a dedicated trapping balloon, and it's designed for safe and easy trapping. So as we can see on the image on the top, the Trapit is having a triangular shape auto-stop, and this auto-stop is making sure that the shaft of the device is always stopping at the same position in the hemostasis valve, so it cannot get further than the triangular shape. And therefore the position of the balloon and the distal tip of the Trapit are always on the right position, which is safe, and always inside the guiding catheter, which makes it optimal for trapping. The Trapit is simple and fast, since you don't need any visualization for the position of the tip. So the tip of the Trapit is visible on the angio, but there is no need to check the position. So there's no need for X-ray exposure, which is very fast. The device can be inserted, the balloon can be inflated, you can do your trapping. The device can be deflated, it will remain its very flat shape. Together with a very small 2 French size shaft and also the same size of the auto-stop, there's minimal blocking of other devices. So especially, for example, when using a 7 French, a Trapit can just be left inside the guiding catheter during a procedure because there's no blocking of other devices. So other devices can just be inserted and removed from the guiding catheter and the hemostasis valve. Next to this special shaped shaft, which makes it different from a regular balloon catheter, the Trapit is different from regular balloon catheters because it doesn't have any hydrophilic coating on the shaft or the balloon. So regular balloon catheters are designed for crossing because they need to treat lesions and they need to open lesions, and therefore they need to easily reach the lesions. Therefore they have hydrophilic coating, but the Trapit is really designed for trapping only, and therefore it doesn't have hydrophilic coating, so it makes it less slippery, which is optimal for trapping. So in summary, the Trapit is very safe and fast. There's no need for X-ray exposure to check its position, and since there's no hydrophilic coating, it makes it optimal for trapping. If there are any questions regarding the design of the devices or any technical related questions, they can be asked in the chat. But first I would like to give the word back to Professor LaManna. Thank you.
Suzanne, thank you very much. You show very well all the specific features of these devices that are very important in order to understand when is the most appropriate situation where to use them. So I think that now we have seen very well in this webinar how it's important nowadays to use appropriately specific techniques in order to deal with very complex anatomy, because nowadays any interventional cardiologist face very complex patients because it's part of our ordinary activity. So it's very important the experience of the operator, but even the ability of specific device in the cath lab. We have seen how important it is to manage complex situations like bifurcations, thrombus-containing lesions, and dissection, the ability of a dual lumen microcatheter. How it is important to have a 6 French trappable dual lumen microcatheter, because in 98% of our procedure we use 6 French guiding catheter. So having the ability of micro like the enhancer RX can make our procedure very effective, even with a 6 French guiding catheter. We have seen how it can be difficult to treat very tortuous anatomies, situation where we have a poor backup, or in specific setting like the use of Rotablator, guide extension can be very important. I think the specific features of the Gideon with this soft automatic tip that doesn't lose the shape even after going deep into the right corner in the coronary arteries is a very important characteristic of this catheter. So in general, I think that we have learned today how to use these modern techniques and device to deal with very complex lesions. And I think that in our everyday life this will impact a lot. Thank you very well. Thank you very much. Before stopping, I think that both Roberto and Gabriele have their say. Gabriele, Roberto, please, would you like to say something before closing?
To say a short comment on the use of dedicated trapping balloon as a trap it. I think is really useful in some specific situation, like when you have a guide extension, you need to remove your microcatheter because the size of the shaft is smaller than a regular balloon, and you have you don't have a friction at the level of transition. This is very important. The second point is that is a dedicated trapping balloon, so you cannot put your wire inside, and you can use many times without having a damage of the balloon, because with normal balloon we can use as trapping balloon, but after 1 time or 2 times we are not able, our shaft is going to have a kinking, and we are not able to use in this situation. And sometimes you can have some mistake of your colleague. It can mislead. You are asking for 2.5 millimeter balloon for trapping, and they give you 1.25, and is a really cumbersome situation, because you risk in retrograde to lose everything. So this is my last comment. Thank you, Alessio and Gabriele. And if Gabriele want to say the last word, and see you to the next webinar.
Okay, thank you, Roberto. No, just to conclude, saying that this device could represent a solution to overcome and simplify complex PCI. So the concept of complexity is a relative concept. If you are able to use the correct device in the correct way, we can simplify and overcome some different or cumbersome situations. So this is the most important message from this experience that we have the opportunity to share together. So thank you very much.
Great. Thank you, everybody. So we will see you to the next webinar coming soon.
Bye-bye.
Bye-bye. Thank you to all those who attended this webinar. Bye-bye.
Thank you.